Thanks everyone for joining us. My name's Ariel Delaney, the Deputy Director with Rotary and Malaria Partners. We're really happy to host this webinar today as part of our regular webinar series, which aims to engage both Rotarians and the malaria prevention community on unique topics of interest made accessible to everyone. Rotary and Malaria Partners and Rotarians Against Malaria Global are honored to present today's webinar. The mission of both organizations is to engage Rotarians around the globe in the fight to eliminate malaria. In addition to its Rotary advocacy work, Rotary and Malaria Partners is in various stages of training and equipping over 1,700 community health workers in Zambia and Uganda in conjunction with the respective ministries of health. RMP is also supporting malaria public education in the Gambia, indoor residual spraying in Ghana, among other efforts. Separately, Rotarians Against Malaria is a Rotary International affiliate that has partnered with the Alliance for Malaria Prevention, providing comprehensive training for malaria intervention programs in 20 sub-Saharan African countries. We had originally intended to bring together the global malaria prevention community for a one-day malaria symposium, actually this month, at the Rotary International Convention in Hawaii. However, COVID-19 interceded. And with the unfortunate necessity of having to cancel the venue, we asked the symposium participants and speakers to bring their knowledge and insight to the malaria prevention community in a different format, virtually, via these webinars and some videos. Our sponsors for today's webinar include UNICEF, the UN Foundation, Pilgrim Africa, the Juniper Foundation, State Farm Insurance, and the Rotary Club of Long Beach, California. We are sincerely grateful and appreciative for their financial support of the program. Today's webinar, entitled Leaving No One Behind, will focus on malaria prevention in young children, pregnant women, and refugee populations. Our speaker today is Valentina Buj de la Huyer. She is the Global Malaria and Health Partnership Advisor at UNICEF. Valentina has worked to assist communities to continue scaling up integrated malaria interventions and works to foster greater harmonization among global malaria initiatives. Much of her time is spent working in malaria endemic countries, including the Democratic Republic of Congo, Angola, Kenya, Madagascar, Cameroon, and Mozambique, where she supports countries in the development and implementation of UNICEF's Global Fund grants for malaria, as well as with the coordination and distribution of long-lasting insecticidal nets, antimalarials, malaria diagnostics, intermittent preventative treatment during pregnancy, seasonal malaria chemoprophylaxis, integrated community case management, and the development of supportive community health systems. Valentina has also worked with the World Health Organization's Global Malaria Program, the International Rescue Committee, the International Organization for Migration, and the United Nations Development Program. She has a master's degree in public health focused on malaria control in refugee populations, as well as a master's degree in international affairs focused on economic and political development of refugee law, both from Columbia University. She's working toward a Doctor of Philosophy and Epidemiology at the Swiss Tropical and Public Health Institute at the University of Basel, which is focused on the improved delivery of malaria interventions in difficult contexts. Please note that Valentina is based in Geneva and there will be a slight delay in the slide transition. Thank you for joining us today, and I'll now hand over to Valentina.
Brilliant. Thank you so much, Ariel, for that wonderful introduction, and thank you so much to Rotary and Malaria Partners and to the sponsors for inviting me to this webinar and to give you just a short overview about malaria and how and why it affects children and pregnant women. We'll be talking a little bit about the data. We'll also be talking about other particularly vulnerable groups, especially refugees and those living in peri-urban areas, what impact climate change might have on malaria, and challenges and opportunities in protecting children under 5 and pregnant women from malaria. Every 2 minutes, a child under the age of 5 dies from malaria. According to the 2019 World Malaria Report, children under 5 accounted for 67% of all malaria deaths worldwide in 2018. Most of these deaths occurred in sub-Saharan Africa, where approximately 24 million children were estimated to be infected with the deadliest form of malaria. Globally, approximately 44% of children never make it past their first 30 days. The 3 main killers subsequently are pneumonia, diarrhea, and malaria. Children from poorer households rural areas, and mothers with less education are at higher risk of dying before the age of 5. The burden is quite uneven across regions. In 2018, more than half, which represents 3.3 million of all children under the age of 15, died in sub-Saharan Africa, followed by 1.8 million in Central and Southern Asia. Some estimates and some studies put malaria as the cause of up to 24% of total child deaths in sub-Saharan Africa. So why are children under 5 and pregnant women at greater risk? Malaria transmission intensity and the human force of infection are measured using the entomological inoculation rate. The abbreviation is EIR, which represents the average number of infectious mosquito bites per person per year. Some people are bitten by mosquitoes more than others because of proximity to larval habitat, a differential attractiveness to mosquitoes, and other reasons. Some places, such as the Democratic Republic of Congo, have an EIR of greater than 200 potentially infectious bites per night per person. Acquired immunity greatly influences how malaria affects an individual and a community. After repeated attacks of malaria, a person may develop a partial protective immunity. Such semi-immune persons often can still be infected by malaria parasites, but may not develop severe disease and are frequently asymptomatic. The clinical manifestations of malaria, the severity, and the course of a clinical attack depends on the species and the strain of the infecting Plasmodium parasite, as well as the age, genetic constitution, the immune status, malaria-specific immunity, and the nutritional status, particularly of children. The mode of transmission of infection, whether an individual was on prophylaxis or had previous exposure to malaria drugs, will also affect the clinical manifestations. The likelihood of death is increased in children with pre-existing health problems such as anemia, malnutrition, and immunocompromised states. Newborns will be protected during the first few months of life, presumably by maternal antibodies transferred to them through the placenta. As these antibodies decrease with time, these young children become vulnerable to disease and death by malaria. Pregnancy also decreases immunity against many infectious diseases. Women who may have developed protective immunity against Plasmodium falciparum, the most severe form of malaria, tend to lose this protection when they become pregnant, especially during the first and second pregnancies. In children, symptoms are varied and often mimic other common childhood illnesses, particularly gastroenteritis, meningitis, or pneumonia. Fever and headache may be the sole symptoms, or gastrointestinal symptoms may predominate. Fever is usually the key symptom, and children are more likely to have a very high fever, above 40 degrees Celsius, which may also lead to febrile convulsions. Nausea and vomiting are also common, especially in an infection with Plasmodium falciparum, and may hamper treatment with oral antimalarial drugs. Pneumonia and acute diarrhea are the most common comorbid conditions associated with malaria, and both are strong predictors of mortality. As I mentioned, falciparum malaria is the most severe form of malaria, with fatality rates up to 15% in non-immune children with anemia and the most common outcomes are anemia and severe respiratory distress if appropriate therapy is not promptly instituted. In 2019, the top 10 emergencies in the world were in Yemen, the Democratic Republic of Congo, South Sudan, Afghanistan, Venezuela, the Central African Republic, Syria, Nigeria, Ethiopia, and Somalia. As of 2017, it was estimated that 16.2 million people were newly displaced. This is equivalent to an average of 44,000 people being forced to flee their homes every day. Children below the 18 years of age constituted about half of this refugee population in 2017. In contrast to trends in previous years, the proportion of refugees living in urban areas declined slightly. However, more than 50% of refugees living in urban areas are no longer in camp settings and are more at risk because they are being put in highly impoverished settings so poor housing, proximity to larval habitats, and at higher risk for malnutrition. The disease risk in complex operating environments among refugees is again related to high levels of mobility, poor living conditions, decreased access to health services often caused by ongoing conflict, the collapse of the health system, ethnic, cultural, linguistic, or other barriers, weakened immunity because of multiple infections and malnutrition, especially during the first phase of displacement, poor water containers and poor water management, open defecation sites and poorly maintained latrines, increasing fly numbers and disease transmission, a movement from low to high transmission zones, and women of reproductive age and children constitute a majority of the refugee populations. 15 countries are responsible for 80% of the total malaria cases worldwide. This means that there are 3.2 billion people globally at risk of the disease. Please note that 95% of malaria deaths are in sub-Saharan Africa. The 10 most affected countries in Africa in order are Nigeria, the Democratic Republic of Congo, Mozambique, Uganda, Burkina Faso, Ghana, Niger, Cameroon, Mali, and Tanzania. There is one country in the Asia Pacific, namely India, who also counts among these high burden, high impact countries, as we call them. The High Burden, High Impact Initiative is a partnership initiative which is looking at tailoring country efforts to ensure that agencies and partners and governments whose on-the-ground presence is in nearly every malaria endemic country is using all of its flexibilities to adapt to the country context to ensure that opportunities and challenges are being adapted and are being addressed in real time. This is a map of the global Plasmodium falciparum incidence overlaid with refugee and IDP sites. You will note the overlap of where refugees are coming from and where they are fleeing to. 3 of the top 5 refugee hosting countries, each with a refugee population of over 1 million, namely Sudan, Uganda, and Pakistan, are all malaria endemic. I will now go into the different interventions that we are using to control malaria incidence. One of the most important that I'm sure you have heard about is long-lasting insecticide-treated nets. We often also use the abbreviation ITNs, which means insecticide-treated nets. These are extremely important as ITNs are estimated to reduce mortality rates by 55% in under 5s in sub-Saharan Africa. In real terms, for every 1,000 children sleeping under a mosquito net, we can save up to 6 lives. However, as of 2018, the percentage of sub-Saharan African households with at least one ITN is 72%. However, only 42% of households had sufficient ITNs for all household members. There is also considerable variation in coverage across countries in sub-Saharan Africa, ranging from a low of less than 20% to a high of approximately 90%. Consistent use of an effective insecticide-treated net, particularly one that is long-lasting, by at least 80% of the population living in endemic areas, can result in up to 20% reduction in child deaths. UNICEF works across the entire spectrum of LLIN deliveries. We work in procurement, and since 2000, UNICEF has procured and helped to distribute over 400 million mosquito nets in over 50 countries. And UNICEF also acts as a procurement agent for countries and donors. In terms of distribution, we support distribution of nets through routine systems, which includes antenatal care and at immunization contact points, and also contributes to mass campaigns. We not only help with the procurement and distribution of nets, we also work to strengthen country supply chains. Because the use of nets is as important, if not more important than ownership, UNICEF also supports the training of community health workers and reaching out to pregnant women and children to ensure increased use. We work closely with communities and faith-based leaders to ensure the promulgation of healthy behaviors, in particular, sleeping under a bed net every night. In terms of malaria and pregnancy, this is one of the areas where UNICEF is striving to work mostly because malaria can infect the placenta and the fetus, which leads to low birth weight, through intrauterine growth, retardation, and/or prematurity. Over half of the women who become pregnant live in tropical areas of Africa with intense transmission of Plasmodium falciparum. This represents approximately 125 million women. An estimated 10,000 of these women and 200,000 of their infants die as a result of malaria infection during pregnancy, including as a result of severe malaria anemia, which contributes to more than half of these deaths. Infection with malaria during pregnancy is estimated to be responsible for 20% of all low birth weight deliveries and 35% of preventable low birth weight babies. Estimates suggest that 11% of newborn deaths and 6% of all infant deaths may be caused by this low birth weight associated with malaria in pregnancy. One of the major problems is that most countries have low coverage of intermittent preventive treatment during pregnancy, which makes antenatal care a missed opportunity to deliver anti-malarial care. UNICEF is also supporting the delivery of bed nets at antenatal care visits. You'll see here why there are so many missed opportunities. And you'll see that the need to increase not only adherence to antenatal care, but increase the coverage of intermittent preventive treatment. Intermittent preventive treatment is one of the cheapest and easiest methods of malaria prevention. A tablet costs approximately 4 cents, a dose costs 12 cents, and a full course of all doses costs less than 50 cents. The incremental cost of adding IPTP to existing antenatal services is $1.10. The Rollback Malaria and Pregnancy Working Group has issued a call to action 5 years ago, which aims to highlight the need to ensure that we are covering this missed opportunity of where women are attending antenatal care, but are not receiving this low cost and highly effective intervention. One of the reasons we are so focused on this area is that globally, 83% of pregnant women had at least one antenatal care visit with a skilled health provider. Yet only half of these had the recommended minimum 4 antenatal care visits. The necessity for a full package will help with screening for maternal illnesses, provision of iron, folic acid, tetanus immunization, and is also an opportunity for counseling on family planning, birth, emergency preparedness, and smoking cessation. Antenatal care is also an opportunity to promote the use of skilled attendants at birth, which will help reduce emergency obstetric care and helps reduce maternal death, as well as neonatal deaths, so the death of the infant. Diagnosis is the first key step in malaria case management. To ensure children are receiving appropriate medication for malaria, they must first receive a confirmatory diagnosis, either through microscopy or a rapid diagnostic test. If the diagnostic test is positive or negative, will determine what treatment should be applied. However, approximately 40% of children with fever in sub-Saharan Africa do not present for treatment. Of those who do seek treatment, approximately 20% are seeking attention in the informal private sector, which has low testing rates and low availability of ACTs. And this puts pressure on the currently efficient and effective anti-malarial, which is the artemisinin combination therapy, which could lead to increased drug resistance and leads to children being treated incorrectly. It is estimated that every child under 5 in sub-Saharan Africa has approximately 6 febrile episodes, thus highlighting the need for quality access to rapid diagnostic tests to ensure that each one of these fevers is either confirmed positive for malaria or negative, allowing for treatment of the cause of fever. UNICEF is working assiduously also to scale up anti-malarial treatment. We use a forecast and updated information sourced from countries to establish high visibility procurement. We also provide in-country support for quantification and forecasting, quality assurance of the medications that are delivered, as well as monitoring and evaluation to track where these drugs and these diagnostics are being delivered. We are also highly involved in the development of pediatric and child-friendly formulations of antimalarials. UNICEF is a recognized leader in supporting community efforts through the training of community health workers and mobilizing resources to extend and strengthen the community platform of malaria, pneumonia, and diarrhea. known as integrated community case management, as well as empowering communities through our communication for development efforts. This is aimed at meeting the greatest gap in potential mortality reduction, as there is a large unmet need for treatment. At present, we know that only 35% of children are receiving the correct treatment for diarrhea, and only 31% of children with suspected pneumonia receive an antibiotic. As I mentioned previously, on average, less than 40% of children with a fever who have suspected malaria are receiving the appropriate anti-malarial. One of the reasons why UNICEF is working in this area is that we work very closely across multiple sectors. As I mentioned, we used immunization and the EPI platform. We also use the antenatal care such that we can target pregnant women and their children. We also work in the nutrition area, and we also work in the water and sanitation. One of the core pillars of UNICEF's health strategy is also health system strengthening, which helps us to ensure that we are achieving integration in service delivery. We are working with community health workers and strengthening primary health care. Our mandate also covers adolescents, which ensures that we can work with pregnant adolescents, which happens frequently in lower middle income countries. And it also ensures that we can work on severe malaria. As I mentioned, as children age, their immunity changes and they are more likely to develop severe malaria if they move out of the pressure of infection. While there has been tremendous progress between 2000 and 2015, as of 2018, we are still losing nearly 300,000 children every year to malaria, mostly poor African children. Malaria is still the fourth highest cause of death in children under 5 years of age and accounts for 10% of child deaths in sub-Saharan Africa. Malaria and poverty are a highly vicious cycle. Poor rural populations in malaria endemic areas often cannot afford the housing and bed nets that would protect them from exposure to mosquitoes. Education and lack of knowledge, which results in cultural beliefs, will lead to the use of traditional ineffective methods of treatment and prevention. Human activities necessary for economic survival can also create breeding sites for larvae, as well as agricultural work, such as harvesting, may force increased nighttime exposure to mosquito bites. Raising domestic animals near the household may provide alternative sources of blood meals and could decrease human exposure. War and migrations, voluntary or forced, also expose non-immune individuals to an environment with high malaria transmission. It has been noted that countries with higher proportions of their population living in poverty, less than $1.25 per person per day, have higher mortality rates from malaria. And within countries, malaria parasite prevalence rates in children are highest among poorer populations and in rural areas. We are, however, in a quickly changing context. Even as early as 1947, the posited solution to malaria was economic development. As we move into the necessity to achieve the Sustainable Development Goals, we must not forget that malaria is primarily a disease of underdevelopment and social deprivation. UNICEF's investments to bring down the malaria burden have made consideration of malaria eradication possible. And as the malaria burden goes down, we will note that less fevers are malaria, pointing to the necessity for integrated service delivery for the three main killers of children, namely pneumonia, diarrhea, and malaria. As I'm sure you've heard in the news and in previous webinars, the problems of COVID and its undercutting of essential health service delivery risk to put us back into the situation we were in 2000, namely millions and millions of children being at risk and dying from malaria. Preliminary data already from 2009 were showing a pronounced increase in malaria infection rates throughout Africa, and we're seeing that malaria can increase very quickly. A couple of case studies here, such as Uganda, where we saw that the infection rate increased by 40% in just 3 months, resulted in over 2.4 million malaria infection cases. Burundi also experienced a malaria outbreak, which led to nearly 8.9 million malaria cases and over 3,000 deaths recorded throughout the country. In South Sudan, 37% of the emergency health care services were for children under the age of 5 who were infected with malaria. Experts have identified malaria as one of the diseases most sensitive to climatic factors. This is due to the fact that the National Oceanic and Atmospheric Administration has noted increased rainfall and subsequent flooding, which can be directly attributed to global warming. The 9 warmest years on record have all occurred since 2005, with 2019 being the second warmest year in this 15-year period. A warmer atmosphere causes more evaporation, which results in greater amounts of water available for precipitation. This increase in water vapor leads to greater risk of heavy rains and flooding. Experts also believe that climate change has altered the patterns of flooding in Africa as a result of more frequent and prolonged heavy rains. Many African cities, especially those located in low-latitude countries, have recently experienced unprecedented extreme flooding. As heavy rainfall stops and floods gradually recede, stagnant pools develop, providing an ideal habitat for mosquitoes and resulting in an upsurge of malaria transmission. The extreme flooding in 2019 throughout sub-Saharan Africa undoubtedly directly contributed to the increase in severe malaria outbreaks throughout many countries. UNICEF's malaria strategy is closely aligned with the global technical strategy on malaria, as well as the action and investment framework against malaria. As Ariel mentioned in my introduction, we work very closely to increase investment and resource mobilization, including domestic resources, and alignments with initiatives such as the Global Financing Facility and the Global Fund for Action Against Malaria. We also work on integrating malaria into health systems, in particular the support and use of maternal, neonatal, and child health platforms, such as antenatal care, the expanded program on immunization, and community health workers. As part of UNICEF's equity agenda, we focus specifically on vulnerable and marginalized populations. One of our most important investments is on improving quality and use of data, as well as monitoring results, and strengthening and facilitating cross-sectoral engagement, and ensuring that communities are in the driving seat of their malaria control and prevention efforts. UNICEF's mandate is specifically to look at pregnant women and children under 5. This is one of the reasons why we are so focused on equity. We have noted that poorer, less educated, and rural women have been shown to have lower coverage and access to malaria control and experience more discrimination and disrespect in facilities. We are focused on reducing disparities, in particular advancing policies and ensuring we are intervening at the community level, and reducing barriers to access, including distance and cost. We are focused very much on what is working. We have a strong policy influence at all levels. We also work on market shaping and supply chain optimization, as well as innovations. We work much on technical support as well as coordination, procurement and supply chain strengthening, and again, a very strong focus on integration of malaria control into health systems, particularly at district level. There is, however, a very strong need to continue to push through to universal coverage. We know that a number of countries are more heavily burdened by malaria, and their efforts to combat the disease are undermined by weak health systems and a lack of sustained long-term financing for the procurement and distribution of malaria commodities. Intense efforts are still needed to extend vector control and ensure universal access to bed nets, anti-malarial treatment, rapid diagnostic tests, and their benefits, as well as innovative new delivery mechanisms such as seasonal malaria chemoprophylaxis. I very much like this quote by the UN Secretary General. Malaria control has proven to be one of the smartest investments in health we can make. That is why it is one of the UN's priorities. When we target our funds in proven malaria control interventions, we create healthier communities and more robust economies. Now, more than ever, partnership can ensure we can build on our successes and ensure we leave no one behind. And with that, I thank you very much for your attention, and I look forward to answering any of your questions.
You mentioned cerebral malaria in your presentation. Could you explain a little bit more about it in children and how what the long-term impact is for children who survive it?
So cerebral malaria is actually just one part of severe malaria, which is a multi-system, multi-organ disease. When uncomplicated malaria is allowed to progress to severe malaria, you can have 4 different conditions, one of which is cerebral malaria, severe malarial anemia, respiratory distress, and hypoglycemia. Cerebral malaria is defined by WHO as an unrousable coma in patients with falciparum parasitemia. Most children with cerebral malaria can regain consciousness within 48 hours and seem to make a full neurological recovery. However, 20% will die, and up to 10% have persistent neurological sequelae. One of the main problems is that there are no clinical features that are very clear for severe malaria. The well-known are fever, impaired consciousness, seizures, vomiting, and respiratory distress. However, access to controlling severe malaria is often very limited because it can only be done in tertiary health facilities. It's one of the reasons why all partners, including UNICEF, are so focused on ensuring that uncomplicated malaria is treated within the first 24 hours of onset of symptoms. If we can stop uncomplicated malaria progressing to severe malaria, we can reduce malaria mortality, especially in children under 5.
Thanks, Valentina. Another question I have, Nigeria is one of the most populous countries in Africa, and you mentioned that they also are have the highest malaria burden. Do you know why that's the case and why more isn't being done to lower the incidence?
So we actually are working very hard to lower the incidence. The main problems undercutting Nigeria, in addition to the challenges I outlined, is Nigeria's highly dense population. So unfortunately, the transmission continues. It is also a very poor country, especially in rural areas. So access to malaria prevention and diagnosis and treatment is often very low. The systems in the country, especially health systems, are very poor. So all of these challenges together contribute to Nigeria being the highest incidence. Countries like the DRC, which are very large, have more rural populations, which again have problems of last mile access. So being able to get into rural poor populations is often very difficult. It's also very challenging geographical terrain. Both of these countries also have severe security issues. So you'll see complex operating environments, plus unfortunately also the outbreaks of conditions such as Ebola.
You referenced the 2019 Uganda malaria outbreak. At that time, just for our audience, Rotary Malaria Partners actually helped increase the supply of blood transfusion in Kampala. What accounted for the sudden surge last year with malaria, and how could this kind of happen in other countries, particularly in the context that we are now?
So unfortunately, COVID-19 is undercutting essential health services. So it's also weakening and overburdening already weak health systems. With this problem, and you will have less and less access to, again, early diagnosis and treatment for uncomplicated malaria will lead to greater severity. That will increase the number of cases. It increases the malaria reservoir, and therefore you increase malaria mortality. Unfortunately, Uganda was also a perfect storm of lack of access to LLINs caused by financial delays. Plus, we also had a large influx of refugees.
RMP, we support a lot of community health worker projects, namely, as I mentioned earlier, in Zambia. We know it's an effective method for healthcare delivery. Why don't you think more countries in the global south are actually adopting this method?
So UNICEF is a leader on the institutionalization of community health systems, which we know is an effective and proven delivery system. However, community health workers are again at the last mile of delivery, or as my boss often calls them, the first mile. So having to get to that first mile has economic and also geographical barriers to access. So how we can overcome those takes innovation, creativity, and finances. Community health workers are often also driven by volunteership. Many countries have not institutionalized them as part of the health cadre. So keeping them in post and keeping those who are trained is often very hard. So how can we ensure that we again institutionalize them as part of the formal community health system and ensure that they are salaried?
We've already received a number of questions from the audience. I will say it's quite a global audience today. I'm just going to start by asking the first question that I received. Recognizing Nigeria's challenges, what is the current UNICEF effort to improve malaria interventions in the country?
So we're working across the spectrum. So we're not only working on LLIN deliveries, as I mentioned, we're working not only on the campaign modalities. So campaigns are a highly effective way of getting malaria prevention up quickly. In particular, because you'll do a universal coverage campaign, you can do one very quickly. Hopefully, if your bed net will last the 3 years that it's supposed to, which requires care and adequate use of the bed net, we will say that for approximately 3 years, those bed nets should be effective. However, in between campaigns, you will also have new pregnancies, new children, new families being created, or you will have new refugees. You'll have new populations who are coming in. This highlights the importance of ensuring that we have routine bed net distributions in between to ensure that we can mitigate these sort of ups and downs in coverage. Security considerations are always very difficult, but it's also one of the reasons why we're focused so much on ensuring delivery of malaria diagnosis and treatment in complex operating environments. We're also looking at innovative systems like seasonal malaria chemoprophylaxis, which targets school-age children, and ensuring again that we are increasing access to IPTP as best as possible. UNICEF has been working very carefully and very much looking at where we're seeing right now interruptions in essential health services. One of our big concerns is that if we are not diagnosing and treating those malaria cases within those first 24 hours of onset of symptoms, particularly in children, it will progress to severe malaria, which mostly leads to death, unfortunately.
The next question we have is, how great is the problem with other forms of malaria, such as Vivax or viral infection?
So they have very different modes of infection. So unfortunately, falciparum, because of its ability to transfer to severe malaria, is highly lethal. Vivax has a different form which can sequester in the liver. So it's one of the forms that you'll see, and you'll have heard stories about not being in a malaria endemic area anymore, and you'll have another infection. We're still tracking and we're still learning about Vivax and its ability to be lethal. In particular, again, we're working in countries such as India to track and to reduce infection with Vivax. Ovale is another very interesting parasite because both Ovale and Malariae are more closely related to Vivax, and so they have very low infection rates. And very low prevalence rates. They range between 2 and 5% globally. The other that we're tracking closely is now LESI, because it has the ability to transfer from the simian population, from monkeys to humans, and so it was one of the first that we saw in a trans-species transfer. But again, falciparum is as the most lethal form, is the form that we really need to try to control.
We have another question related to, can you explain UNICEF's role with both advocacy and community level implementation?
So in terms of advocacy, we do advocacy both upstream and downstream. In particular, we advocate for policies that are child friendly and maternal health friendly with government. So ensuring that, again, the policies that are being implemented at country level will target the most poor, the most vulnerable, and the most marginalized, especially children, pregnant women, and dispossessed populations such as refugees. In terms of community level engagement, we have very clear social and behavior change policies. We usually refer to them as called communication for development. So again, working with communities to empower them with knowledge and information on healthy behaviors. They range the gamut from washing your hands, using your bed net, exclusive breastfeeding. So again, using this gamut of intersectoriality in the range of areas that we cover.
We have a fairly technical question, but this one is, I would like to know your strategy on capacity building for staff and local counterparts on quantification, forecasting, and tracking of malaria commodities to ensure sufficient stocks and distribution to all of the patients who require the commodities. Can you comment on that, Valentina?
Sure. So one of the great things about UNICEF is how hard we've worked on increasing immunization, and I'm sure you'll have seen some of the great news on polio eradication around the world, because that helps us using both forecasting and forecasting the needs. It helps us to train local counterparts on correct storage of commodities in the warehouse. It helps us use good supply chain delivery systems. Plus, it also helps us to then use our contact points, plus also the disease burden estimates, to ensure that we're doing the right forecasting for countries. We do this as part of a partnership effort, in particular when we're helping prepare global fund proposals, who have a very strong area on both the need for funding, and so that we can know what the need is, what is financed, and what's the remaining gap, in particular because with these forecasted needs, we can then work to ensure that these are covered.
We have another question related to level of commitment from UNICEF. In the last 2 decades, UNICEF supported and funded MIP, but in recent times, I'm not sure of the same level of commitment. Is this due to the funding level or change in vision focusing more on children under 5?
So there've been a couple of major changes. So one of the big changes that happened between, I would say, 2005 until about 2011 was a focus on universal coverage, and in particular for bed nets. Because again, this high level of community-wide use of bed nets gives you a very strong herd immunity, or it's a parallel to herd immunity, especially if 80% of those bed nets are being used. It undercuts a little bit the ability to target certain populations, be they pregnant women or children under 5. However, we are pushing very hard to come back to ensuring that we can increase ANC, in particular, a recognition of this missed opportunity of ensuring all 4 doses of IPTP are given at ANC contact points, and again, using the immunization platform. However, malaria and pregnancy has definitely not dropped off of our radar. It's still a very strong central point of our strategy. And in particular, we see it as a missed opportunity. As a matter of fact, the call to action on malaria and pregnancy was lodged at UNICEF House on World Malaria Day 2015.
What is your thought about engaging community health workers to identify pregnant women in the community and refer them to attend ANC? Those who are eligible and had not gone for ANC could be given an SP dose at the community and referred to ANC for other services. By this way, complement comprehensive ANC services.
So community ANC or community IPTP administration is currently being evaluated through a number of pilot projects, including in the DRC and in Madagascar, under a UNITAID project called TIP-TOP. There's been a lot of questions about IPTP and SP administration at the community level because of the need to be seen by a well-trained community health worker. As I mentioned, antenatal care is a strong opportunity to diagnose whether there might be any problems with the growing child, or whether there might be any problems with obstetric care. One of the main areas that we do focus on is ensuring skilled birth attendance, such that you have assistance at your time of birth should there be any complications. So at the moment, the recommendation is that ANC still be done at facility level, but it is an innovation to do it at community level, and we are trying to think it through, because again, it's a very cheap intervention. It's also one that's highly effective, and the drug that is used, sulfadoxine pyrimethamine, is reserved for intermittent preventive treatment during pregnancy.
And we have one last question for today. It states that there are many stakeholders in the fight against malaria, yet malaria continues to kill a child every 2 minutes. Why is the reason for that?
So access. So really, we have to ensure that we are getting to universal coverage, that we're finding every child, that we're finding everyone who might be infected with malaria, and that we get them to sleep under a bed net, that we can ensure that at the moment of diagnosis and treatment, so as within 24 hours of that onset of symptoms of a fever in particular, that we can ensure whether or not it's malaria. So it's cheap. I mean, it really is cheap, and we're pumping in billions of dollars into it with the support of individual donors like those in Rotary, those large-scale donors like the Global Fund, the U.S. President's Malaria Initiative. We've seen that some of the needs to cover are they're cheaper than a cup of coffee in the United States. We know that with $5, we can ensure procurement of a bed net all the way through to putting it over a necessary family. $2 will ensure access to an effective anti-malarial, and $1.10 will ensure you access to a full dose of IPTP. So these are really, really, really very cheap. And I mean, the last time I was in the U.S., and definitely not in Geneva, I can't buy anything for $1.10, but I could definitely buy. I definitely could buy malaria prevention for a pregnant woman. So, as I said, part of it is also looking at this integrated service delivery. As we do better and better about getting bed nets out there, more and more of the fevers will luckily not be malaria. Unfortunately, we still know little kids. I mean, those of you who have little kids, they get fevers all the time. In sub-Saharan Africa, so many of those causes of fever are bacterial, virological, and they're highly lethal. So it's one of the reasons why we really focus on this integrated delivery of ensuring access to, be they antibiotics to cure the pneumonia, or ORS and zinc, which again are really easy, cheap, effective ways of controlling the diarrhea. And fortunately, we are very lucky. We have good, stable malaria diagnostics, which allows us to go down this algorithm and this pathway of, if a child is infected with malaria, we can treat them, and we can treat them quickly. I like the question on severe/cerebral malaria, because it's really somewhere we should never get to. It's cheap, it's easy to control malaria. So we shouldn't be seeing high levels of severe malaria, but it's still going to take money. It's going to take people on the ground. It's going to take investments in health systems. And it's going to take getting out to that last mile. And that last mile is geographically and socioeconomically challenging.
Absolutely, and we also recognize that funding for malaria globally has kind of decreased, and now with competing priorities in terms of the global response to COVID-19, it's even more important for partners to come together in terms of the work for preventing malaria. I do have one more question actually, and this is from India. I want to know, what are your thoughts regarding asymptomatic malaria in children and malaria elimination?
So definitely malaria elimination is where we're going. Asymptomatic malaria is more common in adults. And one of the reasons why is because children, one, have a lower blood volume. And as I said, once they're infected with the malaria parasite and their blood cells start breaking apart, we see enlarged spleens, we see these high fevers, including with vivax malaria, which is more prevalent in India. So our problem with the reservoirs of malaria are mostly asymptomatic adults. India has actually been a major leader, and some of the great gains that have been made in bringing down malaria have been done in India, in states like Odisha. And so the Indian government's leadership on malaria elimination has really been exemplary, and it'd be great to put that model out into the rest of the world. But the asymptomatic reservoir is one that we're looking at, and we're looking at creative ways of doing diagnosis such that we can again treat that reservoir and get those parasites out of people.
So screening of all children be a part of routine malaria screening, in your opinion, then?
I think there are strong opportunities to do diagnosis and treatment, and using different innovations like seasonal malaria chemoprophylaxis, which is a prophylactic dose to school-age children given over 4 months during the season of highest transmission, particularly in the Sahelian area where the drug is most effective, have shown very good methods of going forward. There's a lot of new pilots and a lot of new opportunities to do mass screen and treat, which again is doing these diagnostic opportunities to look at the reservoir in children and in adults. Unfortunately, it's expensive, and it's a lot more expensive in terms of going out. And it always needs, when we do these mass screen and treat, because unfortunately children can be reinfected. It isn't until about the age of 5 that we see this acquired immunity be sufficient not to be reinfected with malaria. So it has to be coupled with very strong prevention programs. And we've seen that in countries that have eliminated malaria, that you start to push down the reservoirs, you get the islands smaller and smaller, but you have to keep your eye on the prize. And it can take 10, 20 years of investments in surveillance, in continuing to go out into communities, into screening any of the new travelers coming in. There was a very interesting and sad case. Mauritius is the only country that has eliminated malaria twice. And what happened in between is they had a typhoon or a cyclone that came in. And when all of the healthcare workers came in to help mitigate the emergency from West and Central Africa, they brought the parasite in their bloodstream and reinfected. Mauritius had to go through the elimination strategy all over again. So it's been a warning call that, again, don't take your eye off the prize. And unfortunately, emergencies, refugees, and complex operating environments contribute strongly to raising malaria cases. And we're right in the middle of the biggest pandemic in the world. So we have to really ensure that, again, we stay the course, that we ensure that we are ensuring access to essential health services, in particular malaria diagnosis and treatment for children, refugees, and pregnant women.
Well, thank you so much. We're now at time, Valentina. For further information about Rotary Malaria Partners or about the most recent trends in the battle against malaria, please visit our website at rotarianmalariapartners.org. I want to thank again, Valentina, for your wonderful presentation and helping us answer all these questions today, and thank everyone who has joined us from all over the world.